Welcome everyone to the Dermatology Mastermind, and I'll explain what that's all about. I'm really thrilled to have our wonderful insider, Connie Simmons, talk to us about Diamine Fluoride and all its possibilities. I don't know if we can do it all in an hour, but the myriad of possibilities there are with that fantastic product. Now, many of you, if you can mute your microphone unless we ask you to talk, or I recognize you, it would really help. Thank you. Those of you, there's many of you here that have never been to one of our dermatology masterminds before. And the reason you got an invitation to this one is because this subject is so very, very important. You are all getting my Dermatology Smart Bulletin. And you got on that list, whether you remember it or not, you got on that list because you attended a course with me, or you bought a product from me, or you chose to opt in through my website. So I welcome every one of you. That newsletter does come out on the fourth Wednesday of every month. And try to keep it loaded with lots of up-to-date information, certainly on coding, but on a whole lot of other things too. This mastermind, my company does have AGD PACE certification, and our masterminds are for continuing education credit. Now I already have it in the chat box, but I'm going to announce this several different ways. My executive director, Patty Beeson, is also on the line here, and she needs to keep track because we need to have accurate records in order to offer continuing education. Because this network is set up differently than most webinars, because because we're a membership group, that's why it's a little bit different than you may have had the experience before. So I need your help. If you're not an insider already, if you are an insider, if you know who you are, all I need is a first and last name. But if you're not an insider, I hope you will become one. But I need your full name and your email in the chat box. That is our confirmation record that you were in attendance at this webinar, and the only way that I can issue you a continuing education certificate. Now, I'm going to talk a little bit about what this whole dermatology thing is all about. It is, can you look at me, whoever that is? Dermatology is a word that I made up, and it's the study of dental codes. Not because I love codes, because I'll be honest, I really don't. But what I do know is that codes are really important in keeping track. They are important metrics, and the problem is you don't have any place to find answers. Most of us didn't have any curriculum or background in coding, and so where do you go? Most of the information that you get is from people that, they give you they're going to try to give you the best information, but they may or may not be accurate. God, what is it? Cross. Okay, thank you. So here's some examples of some of the questions that we may, you may want to find the answer to. And what is the answer for the code for lasers and air polishing? When do you use the 0180 perio code? Is it a charting code? The answer to that's no. I'm not talking about that tonight, but the answer to that's no. 0180 is not a charting code. What care do you perform, with SRP? When does it always follow? Does 490 always follow it? You can see the questions there. Many of the questions that you probably asked and just don't know where to get the answers. Well, I'm an answer person, and because, again, this brand of mine, my dental codology, I really do study them. I'm also licensed by the American Dental Association to write and speak on codes. And I'm going to caution you to start becoming a little bit more aware of who you listen to, because unfortunately, even though people give you the information in their, trying to help, there is misinformation printed in articles, said from the podium, and even given by companies, again, not because they're trying to help you commit fraud, but yet that's what can happen. One of the things that I'm honored to mention is that the American Dental Association did recognize my attention and my attendance also at the codes meeting year after year after year, and I was invited to write a chapter in the CDT Companion. I hope that you have available to you both the CDT book as well as the CDT Companion. The CDT book is the one with the official codes. The Companion is how to use the code. Using a book that's expired is like using an expired cartridge of anesthesia. Anesthetic, you shouldn't use it. Now, I've shown the 2018 book there, but you should be 2019, and you can already purchase 2020. New codes are already set for 2020. My dental codology brand, I spread into 3 brands. One is my speaking and my writing. I have a series of 7 books that I've written, as well as my national speaking. We have the Insurance Navigator, which is our education, how to learn about codes, and we're expanding that constantly. And what you're participating in tonight is the Insiders group. And there's 2 parts of the Insiders. Insiders are the membership part, and then we have the DCC. Now, the DCC stands for the Dental Codology Consortium. And what that is a group of interested professionals that want to have a say in codes. All of our masterminds are free to our members. This is a special offer that I have for those of you that aren't members tonight. Now, one of the things we do is all of them are recorded, as this is right now. I'm going to go live to the internet. And what happens is that this is the Insiders group, and once a CE, we grant CE for live presentations, but we also have, is on a recorded things, we have if you missed this particular one, you can take the CE and get CE credit afterwards. So that's another bonus to our members and the availability of those on a regular basis to continue to learn. That's our insider. So we've been had our insiders in August. I really apologize. We're really trying to cut down whatever that noise is. Whew, bad. Sorry about that. Anyway, we have since August of 2017, we've been doing monthly Mastermind, so there's quite a library of courses that you can take there. Another part, again, is the Insiders is the Dental Codology Consortium. This is about codes, and this is about the way codes work. The American Dental Association owns the codes, but the codes are not decided by the American Dental Association at all. By themselves. The listing that you see there are the groups that are voting members of the Code Maintenance Committee. And one of the goals of the Dental Codology Consortium is to have a dental hygienist, as well as office managers, as well as dental assistants, have a say in this. And part of the reason for that is because there's really parts of dentistry that aren't represented, in our opinion, by this group, by the people that are on there. Now, as a dental hygienist that I am, of course, my professional organization is American Dental Hygienists Association. And just about 3.5 years ago, the ADHA CEO, Ann Patrell, contacted the code committee to say, hey, what's it take to get on the committee? And their answer was, they don't have a process for it. We are working really hard to start this anyway, so it's driving me nuts too. Everybody, please mute your mic. Thank you. Thank you. It might be some echo that I'm getting too. Anyway, the committee is, thank you. This is what the committee is now. We're working to get a dental hygienist and others on this committee. The ADHA asked about it. The code committee said they didn't have a process, and then they decided that no one can be on the, no, they're not going to add anybody else to the committee. But we've been very proactively working to be there participate in this group. And I have a big announcement, and those of you, this is for the Insiders. We have an appointment as of just earlier today. I have an appointment with Ann Patrell from ADHA with the Codes Committee because they want to talk to us, and which is a huge step toward that end of having different voting members on that committee. Now, anybody can request a change. You think you don't like codes? Guess what? You can change. You could go right on to ADA right now, and you can see there's a link there. You could put a code in. Probably many of you didn't know that that's possible. Thing is that I'll be honest with you, it might not pass, but you can do it. It is an open committee. It is an open hearing. And again, this group, the group of the Dental Codology Consortium members have been attending this meeting for the last couple years. We've had 5 very active groups that are now submitting for codes to be heard in 2020 to be added in 2015. In 2022, we hope. They include to change, there's some language in the codes that you may not realize that actually limit the provider that can provide the services. This one is, what we said is, it used to be just say by the dentist. Now we want the language added, or qualified healthcare provider as determined by a state practice act. With our practice acts continuing to change, there are, I think there's over 42 states where dental hygienists can provide some level of direct access to patients. Having this code have the proper language in it is really important. So that's one of the things. This is one that we want to have changed. The one that we have very high hope for, because it was one that we brought forward previously, and we were counseled by the code committee, hey, work on it a little bit more, and it's about counseling for the prevention of adverse, as you can see, adverse behavioral, systemic, and oral health effects associated with high-risk substance abuse. We know particularly with the vaping problems that we have, as well as many others, that we in dentistry can play a role. So we think that there's an important code that's needed there. We've asked for some changes in the oral prophylaxis code, to actually call it an oral prophylaxis. We don't think that this is necessarily the direction that we want, but this is what we consider a baby step. And all of this stuff about plaque and calculus, it's really about the disruption of biofilm. And what this does is that when we add the word prosthetics, this also would cover implants, because we don't have any real good codes for implants. So we're asking for those changes in both the child and the adult. We further find that the 4346 code, which was a great addition that we had a couple of years ago, needs modification because it's confusing as all get out, as I'm sure you have experienced. So we're asking for changes with that. A really big change to which we're really very excited is that, I'm going to have you look at the bottom here. It's for an enhanced oral cancer screening, including comprehensive risk assessment, that is specifically asking for a code separate from the oral comprehensive evaluation codes. The reason we feel that this change is needed is the language of these oral cancer screening as part of these codes. They've been there. That was added probably about 12 years ago. And there's words like where indicated. Well, what does that really mean? So this is where it's really important to have its own code. Why? Because the numbers for the incidence of oral head and neck oropharyngeal cancer have increased, not decreased. So that gives you a little bit of an idea of what we're doing. What we really are excited is that we have 2 codes. This is for implants, and this is the preventive maintenance of a fully edentulous case of fixed. This is the mandibular. There's also a maxillary for fixed implants, because again, there's no codes to represent that. And we also have the disruption of biofilm. Now, what we're talking about is different modalities that we have that were not available previously for the disruption of biofilm. And so these are the codes. These are the submissions that we made. And then there is how they're going to pass. Well, we have to get those voting members to vote for them. It's part of our insiders group. Our next meeting is on Sunday, the 27th. Just like this meeting tonight, if you want to have an opportunity just to see what it's about, you can join us. Just contact me, Patty DeGangi. I'm really easy to find. Send me an email, patty@dentalcodology.com, and I'll add you to that meeting so you can hear a little bit more about the work that we're doing there. Again, I invite you to become an insider. I've mentioned being an insider a few times. It includes monthly masterminds, as well as our consortiums, as well as the Smart Bulletin. We have private Facebook. We have lots of discounts. We have a lot of things because we learn together. And what I can offer you is this one time only tonight is if you use this discount code SDF with the hyphen 2019, you can become a member for 50% off. It only is going to be there a week. If you want to do a screenshot of that, so you can do that later, I'd be thrilled to have you join us. Now, what we've learned that we need to do is recognize, because this is where we're going to see how everybody's microphones actually work. a mastermind is about us discussing. It's not just a lecture, it's about discussion. So we're going to go down this list, and real quickly, I'm going to have you say hello if you're here. So Allison W., with that email, are you here? Okay, Angela Craig?
Yes, I'm here.
There you go, perfect. Angela McDougall? Nope. Ashley? Oh, are you here, Angela? Second Angela? Awesome, terrific. Ashley?
Hello, Ashley's here.
Thanks, terrific. Barbie, I know we talked to you already. Thank you. How about Bernice? Are you here, Bernice?
Yeah.
Bernice?
Ice cream.
What, Beth? Betsy? Anita? She looks like she's in Australia, so I don't know if she'll be here. How about Bonnie?
I'm here.
Bonnie Brown? Okay, hi, Bonnie. Great. Brittany?
I'm here.
We got a second, Brittany. Brittany Hayden, I see that, hey, I see that you're on there. I don't have you on this list. That means I need you to make sure you put your information in the chat box, okay? Candy Rodriguez? Okay. Thank you. Candy? Carol? You can see ahead who I'm going to call. So
Carol's here.
Was that Carol Roselle, or was that Carol?
Yes, that was
other Carol.
Carol Roselle.
Thank you, Carol. Carolyn?
Yes, I'm here.
Terrific. Carolyn Zeit. Other Carolyn.
Carolyn
Nope.
Dubose, yes.
Thanks, terrific. Carrie? Carrie's not here yet. Catherine, I know you're here. Hi, Catherine.
Hi, how are you doing?
How about Kathleen Karandi? Kathleen Stewart? Doctor, I'm going to call you Dr. P because I am not sure how to pronounce your name, but I see your name that you are here. Thank you. Sherry Ruffin? Chris Grimes?
I'm here.
All right, Patty, I'm going to have Patty. Can you take this over so I can call you in a different number?
Sure. See, I can't see it. Hi, everybody. Give me a second. I've been checking names off on a list, and I haven't looked at what Patty's doing yet. Oh. Oh, Cherry Ruffin? Cherry?
Hello.
Hi, Cherry. Chris Grimes, we heard from you?
Yes,
This is Chaitanya. I'm here.
Thank you. Krista McConaughey.
Hold on, they're talking.
Krista, you're here?
Hold on.
Cindy Purdy. Cindy, are you here? Okay. Erica Stilson. Stilson, I should say.
They're talking.
Fabian? I'm sorry, I'm not going to get your last name. Fabian,
Yes, I'm here.
Jacqueline Lavada? Somebody crying. A little young for the group, maybe. Jamie Collins. Jamie, are you here?
We're checking the people.
Okay, Jamie? Yonita? Jane Negley?
Hi, I'm here.
Oh, good. Hi, Jane.
Hello.
Jennifer Bruckner. Jennifer Dunham?
Hello, I'm here. Hello?
Okay, good. Jennifer Weitzel.
I'm here.
Hi, Jennifer. Jill Grassmick.
Hi.
Hi, Jill. Still Rodney?
I'm here as well.
Glad you're here. Julie Harvey. Julie Whiteley. Caitlin Lottie or Dr. Lottie.
Mommy needs to get the.
Kendra Sellers.
Baby.
Yeah, I know.
Hello.
Who is this, please?
Hello, it's Kendra. Hello, everyone.
Okay, Patty's got it back. Now I can go check names off.
Okay, so Karen, I think I saw you, Karen Kamisi.
I'm here. Yes.
Terrific. I'm hoping that I changed phones, so hopefully we got rid of some of the disturbance. Catherine Palulo?
Oh.
Kathy Kelly?
I'm here. Hello.
Kendra?
Present.
Kelly Steele?
Hi, everyone. Yeah, this is Kelly Steele.
Terrific. And Kelly, I know we had your name spelled wrong, but we'll fix it right in the box. How about
No worries. Thank you.
Sure. Kirsten Jarvie? Corey, I see you there, Corey.
Hi.
I don't see Lauren. Are you here, Lauren? No. Layla Christensen, I see you here.
Yes, here.
Hey, I got my Canadian friend. Hey, Leo. Hey, Leo. I see you there, buddy. All right. Lisa Funk.
Yep, I'm here.
Terrific. I've got a Linda Alton, but there's another Linda that's in the Dropbox. I mean, that's in the box. Who's Linda? Is that you, Linda Jorgensen? No.
Linda Jorgensen is here. Hi.
Okay. Okay. How about Lindy Pavel? See you there?
Lindy Pavel here.
Terrific, Pavel. There we go. Lisa Hardell, or is it Lisa Hurley? I got one Lisa there, but I don't have a last name.
Lisa Hardell is here.
Lisa Hardell. Thank you. Liz Lewis. I haven't heard from Liz in a long time. Lupe Duncan. Lydia, I see you there.
Lydia's here.
Terrific. Lynn Bryan.
Present.
Terrific. Mandy Toaster. Oops, I think I clicked too fast there. Sorry about that. All right. You know what? I am going to just, you're going to need them because this is taken, because again, we usually don't have this many people. I am thrilled that you're all here. I want to get to content. We're going to go through this. Hopefully you have the microphone. If you don't see your name on this list, or you're not sure, or it doesn't matter, put your full name and your email in the chat box, and we will make sure we get you CE credit. Again, that's what it takes to get the CE credit. That's what I want to do. I want to announce that next month we're going to have Insider Galen Baker, who works with Air Techniques and Monarch in their infection control products, and should be doing an amazing webinar on water safety. And what's really funny about that is that they also have something that's really interesting about tonight's subject. See, they've got this nice vinyl cleaner that really helps clean our chairs and makes it silky smooth and all that. But here's where the rubber hits the road. This is, you see it on there? We've got some silver diamine fluoride that got on that seat. How do we get it off safely? Well, guess what? That's what that product does. The Monarch product helps clean the chair safely, which really brings us to our wonderful Connie and everything you didn't think you wanted to know about SDF. And Connie, what I'm going to do is I'm going to hand it over to you as soon as I, again, to say to the audience that this is a safe place. You can talk about and ask questions about anything, and Connie is very willing to entertain your questions as well as help you to really understand what this amazing new option that we have in our iron carrying silver diamine fluoride. So Connie, go ahead and take it away. Just tell me when you want me to change the slide.
Great. Thank you so much, Patty. Can you hear me well?
Yes.
It's good? Okay. So, well, thank you all for coming. This is so exciting that we have such a huge crowd here tonight. And like Patty was saying, this is a mastermind. So for us that are insiders, that means we want conversation. If there is something that's said or you have a question, Patty, are we having someone monitor the chat box?
Yes, I will go pick somebody to check.
Okay. Okay. So if I don't have a problem, I don't
I
have a
can do
problem.
it.
Okay. Thanks, Vicki.
Anytime, Patty.
Okay, thank you.
So if you have a question, you can put it in the chat box. I'll try to watch it too as we're going along, but I absolutely do not have a problem with you just saying, interrupting and asking me the question right away. So it's a lot of information. I just tell people when we're talking about silver diamine that you really just try to keep an open mind to something that we've never had available before in our toolbox. So keep an open mind. We're going to go forward and please ask questions. Okay, Patty. All right, so silver diamine fluoride. Silver diamine fluoride has only been here in the United States now about 5 years. So in 2014, the FDA granted silver diamine fluoride advantage arrest approval for desensitization. So it is not approved here in the United States as a caries arrest. However, they know how we are using it. And it got brought here so that we could provide this to our providers. The studies, guys, are underway though. The FDA just can't stamp approval on something that the long-term clinical trials haven't been completed. So we are in phase 3 of those trials. We have full certainty that we're going to get stamped approval for caries arrest. However, at this time, silver diamine is approved as a desensitizer. However, desensitization is no anything different to those of us who have already been using fluoride varnish. Our fluoride varnish that we're using every day in clinical practice is approved the exact same way. It's approved as a desensitizer. So we're already using a product off-label, and so the use of silver diamine is not going to be any different than what we're already utilizing other products off-label for. So it is approved for desensitization for adults over the age of 21. It increases dentinal hardness and it blocks dentinal tubules. And I'm gonna guys, just please try to mute if you're on the telephone, just so that we don't get feedback. Thank you. However, I know we have some of our Canadian friends on board with us, and lucky for them, if you cross over to our border to the north, they are actually approved for silver diamine in all of the ways that are shown here. So we know that that's coming for us as well. But just so that you do know, because patients are going to ask, they are going to look up that information on Dr. Google, and they're going to ask you about that. So just kind of be prepared in the way that you're going to respond to your patients about silver diamine. However, in 2016, our product, Advantage Arrest, which is the one and only silver diamine that is manufactured and distributed here in the United States. It's the very first ever dental drug to receive breakthrough therapy designation. And this breakthrough therapy designation is huge. As you can read the very last sentence, it represents the FDA's effort to address an unmet, serious, life-threatening medical need where there is no available therapy. So just let that sink in for a minute. A life-threatening medical need. How many times have we heard about the unfortunate event of kids going to the operating room for sedation, even in practices where they're doing sedation, and unfortunately kids were dying of sedation? We now have something in our toolbox where a lot of those kids could have been offered silver diamine fluoride and possibly have saved some lives. So that's where the FDA is going with it. They know how we're using it. They know how important the medication is. and it's only going to get better the longer that it's in our country. Okay, Patty, you can move forward. Anyone have any questions out of approval or? Okay, so now the American Dental Association, here as posted in the JADA in our journal in 2018, they know exactly how SDF is being used as well. So much to the fact that they have developed evidence-based clinical practice guidelines, non-restorative treatments for both primary and permanent teeth. And if you go back and you read this article, it's readily available on the JADA. But also you can actually download, when I go into offices every day and do lunch and learns for offices, we actually have this in a laminate form. There is a great flow chart that they created that allows you to see where the lesion is, whether it's cavitated or non-cavitated. And luckily, most of these lesions, a treatment option that should be offered to our patients is silver diamine fluoride. They're saying it's just as important to offer silver diamine as it is to offer any other treatment plan option, and that we're really missing the mark as providers if we're not giving the patient all of the education and all of the information about all of the available treatments for the treatment of this carious lesion. So if you haven't seen those evidence-based guidelines for non-restorative treatment, I would encourage you to go and look at that article. Just Google it. You're going to find all kinds of information on that as recent as last year. So it's pretty cool. Everyone following along? Anyone have any questions? Great. Okay, Patty. All right. So how does silver diamine work? So when you look at this slide, you say, and I completely get it. So this comes from one of our scientific officers at Elevate Oral Care. And so a lot of this is stuff that we're looking at and thinking, how am I ever going to explain this to a patient? Or how is my doctor ever going to explain this to a patient? And really what I do is I just try to break it down to the most simplistic form so that we can educate our patient in a way that they can receive it well. So basically, it's the silver nitrate part of silver diamine that is forming silver protein conjugates on the decayed surface of the tooth. So the fluoride part of silver diamine fluoride is helping to form that really super important fluorapatite and hydroxyapatite that we know is so great for the resistance of decay. The other things I have highlighted there are the silver ions that are involved in silver diamine fluoride act directly against bacteria. So treating one site or one tooth in a patient's mouth, you are going to help to lower the cariogenic effect or the cariogenic bacteria of the entire mouth. And I know that it seems kind of corny or cheesy, but when I'm talking to my offices every day, I actually have a picture of like the Walking Dead zombies, because in a lot of the articles that you're going to read about silver diamine fluoride, and I would encourage you to read, watch videos, you're going to see what's called the zombie effect. And the zombie effect has to do with these silver ions affecting the bacteria. So these ions, any bacteria that come in contact with them, this bacteria now dies. So now we have a bacteria that is dead, but it's filled with silver. So other bacteria that eat that bacteria, that silver gets reactivated, and now that bacteria dies. So you can see how we call it, we've kind of coined it the zombie effect, because it works its way throughout the patient's mouth. So for me as a hygienist that applies silver diamine fluoride, if we are going to restore the same day that we are applying silver diamine, meaning we're going to cover it up with some sort of restorative material, I do not hesitate to put silver diamine someplace else in that patient's mouth so that we make sure they're getting this antimicrobial effect of this medication. Very seldom, if I'm applying SDF, And I'm going to tell you about the application here in a few minutes. Very seldom will I ever have anything left still in my dish. I want to get every bit of that medication into the patient's mouth. And I know right now a lot of you are thinking, well, why would I want to do that? Why would I want to turn another tooth black? Why do I want all of these teeth black? I'm going to get to that in a minute, guys. So I know some of you are thinking that, so just hold that thought for just a second. I'm going to skip down to the very last part about how much penetration we have with the use of silver diamine. So into healthy enamel, it soaks in about 25 microns. Into healthy dentin, a range from anywhere from 50 to 200 microns into dentin. So it is a pretty significant soak into those dentinal tubules. And you're going to hear about it in just a few minutes, the desensitizing factor of silver diamine. And this is why, because it's soaking in so well and it's forming those silver protein conjugates deep down in these tubules. Does anyone have any question about how SDF works?
I don't have a question about that, but that word conjugate is not a word I'm particularly familiar with. Can you explain a little bit more about what that word is and what we're talking about here?
Right, so a conjugate is basically, I just think of it as a big blob. So when they show us, and you're going to see it here in just a minute in one of the slides that are coming up, when the silver is acting on the protein and the collagen fibers in the decayed tooth structure or in the demineralized tooth structure or in the hypocalcified tooth structure, the protein is forming with the silver, and it's forming, I look at it like a blob, and you're going to see how these blobs actually are what is occluding. Does anyone else have anything about a conjugate? But thank you, Patty, for bringing that up, because now you're going to make me Google the word conjugate, and it's about Mastermind, babe. It's about Mastermind. So all about the conversation. I love it.
About the conversation. Here we go.
Absolutely. So this is, as you can see, a scan. So in the upper left, this was actually a failed composite restoration, and the restorative material had come out. So you can see the enamel on the sides. You can see the base where there is decay there. And this is actually the application of silver diamine, and those red, we call them nanowires, but you see the red streaks that are going down. That's actually how the SDF is soaking into those dentinal tubules. So you can see what a great masker it is. You can see a very strong layer across the top, and then how it soaks into those dentinal tubules. Okay, Patty. Okay. All right, so here is a 3D CT scan that shows how the silver has soaked in and is sealing those fissures. That the picture on the right, look how far down that silver is showing up, deep down in the please try to mute if you just came and joined us. Thank you. So you can see how far the silver has soaked down in this cross section, and where that silver is still present when they did this cross section. So about this picture, I have something kind of as an aside. There is a hugely important study that's going on right now at NYU that is evaluating the effectiveness of silver diamine fluoride on the grooves of these teeth as comparative to a sealant. So we're hoping that we're going to have great results. The results aren't back yet from that, but as you can see, if a sealant doesn't stay intact, it's not going to protect those deep grooves. And so if we can flow some silver diamine down into those grooves and let it actually soak down into the areas where the sealant isn't going to protect, we're just hoping we're going to have super good results from the study that's going to be released pretty soon. Does anyone have any questions so far?
I do again.
Go ahead, Patty.
I think it's a really interesting study, but maybe it's my just beginning understanding of SDF. But if I thought the reaction was between a broken down surface, so if the surface doesn't have any breakdown, what effect will it have underneath the sealant, or is that basically what the study is looking at?
That's what the study is looking at. I mean, we do know it still has an effect. It's still soaking into those tubules, although the enamel, I guess they're looking at the base of those crevices. Is there going to be some activity where the silver diamine is going to be effective versus just sealing off the occlusal part of that? Does that make sense? But that's good. I mean, I can't wait till we see this study and actually see what they're actually looking at and how they compared it to the effectiveness of a sealant. But we're hoping we have good results. Does that help you, Patty? Or
Yeah, it really does. It's an interesting study. It's an interesting thought process, especially with the,
This is,
again, I think it was in that same FDA evidence-based guideline that you brought up before, or one that came out about the same time, is our use of sealants is so, we're only using sealants about 11% of the time. And so it's like, is this going to make, will this be something that's easier? Is this something that we're going to see differently? I think it's really exciting what this technology is bringing forward.
exactly. And one thing that kind of an aside to this, on mission trips, when I've been on mission trips, and we don't have the availability to do sealants for these kids when we're in the schools and doing their initial screenings, and knowing it's going to be 6 months before they're going to get back into our clinic, we could apply silver diamine to the occlusals of all of their posterior teeth in hopes of keeping those from progressing into decay. It's just an amazing, once your mind opens up to silver diamine and all of the uses, it just, for me, it just goes and goes and goes. So that's just kind of an aside, a way that a lot of times gets used on mission trips when they're screening kids in the schools, and whether the child has decay or not, they are able to flow silver diamine onto the grooves of these newly erupted teeth to try to keep them from developing into something before they can get into the clinic to get a stent.
Connie, we have a question.
Connie? Yeah.
Somebody that wants to ask their own question is fine. Is that you, Lisa? Question.
Yeah, this is Lisa. I can ask it. I guess my question was, if you're placing the silver diamine on an unsealed tooth, can you then apply a sealant later, or should there be a certain time period before you apply a sealant over that?
So that is completely up to you as a provider. So all of the studies that have come back have shown that there is absolutely no effect of silver diamine in terms of dentinal bonding strength. So a lot of providers every day, they ask me, how am I going to flow a composite into this area if you're just telling me that I just occluded dentinal tubules? And then I try to tell them, that's way too scientific for me, and I wish I could give you the answer. But all I can tell you is that all of the studies that we have, and believe me, we have a lot of studies that say it absolutely has not affected bond strength. In terms of enamel bond strength, SDF has actually shown to enhance bond strength when used on an enamel surface. So we have providers who have started using it like before they would put on a orthodontic bracket on a healthy tooth structure. They're using silver diamine to enhance that bonding strength of that bracket. Now, as far as sealants go, you can do anything that you want. If you wanted to apply silver diamine and you wanted to seal over it the same day, what I would caution you, the biggest caution, is that it's going to be an aesthetic issue, not because the silver has oxidized any decay or demineralization, but silver diamine is light sensitive. So if you hit it with a curing light, anything that is not absorbed is going to light up and turn dark. And that is one of the things that I talk to providers about every day who want to restore day of with a light cured composite. If you use something self-cure, like a glass ionomer, which is still the restorative material of choice because of the fluoride releasing abilities, if you're not light curing, that's excellent. You can rinse and dry after you've placed SDF, and you can move right on with your restorative. However, if you are going to use a curing light, meaning a sealant or a composite, or those modified glass ionomers that need a curing light, anything that has not absorbed into those tubules is going to turn dark. So what does that mean? That means that if you are not going to pick up a handpiece and remove any of that staining, that you're going to have some of that show through a sealant material. So there's goods and bads to that. There's goods and bads to restoring over top of SDF and being able to see through it, because anyone else, any other provider that's going to look at that tooth could possibly think there's decay underneath that composite. And I completely get that. It's logical. Most providers who are going to restore day of, they find that they'll take something that was suggested by one of my providers, is he rinses and dries after he places, which I'm going to go over in just a minute. You can actually hit it with a light for about 2 seconds. For about 2 seconds, and that's going to give that SDF time to activate, and then you can kind of see what kind of tooth prep mess, I guess you would say, what you're going to have. And at that time, you're able to go in and either take a Profi cup or a finishing burr and clean up the margins before you decide to restore that day. So that was kind of the long way around answering your question. If you decide you want to flow a sealant over it, you could do it day of, knowing though you're going to have some of that SDF show through. You're not going to have that nice white occlusal. Now, you could apply SDF and you could bring them back in a few weeks and you could seal right over top of that. You're still going to have the darkness, but you're not going to have the darkness of the effect that you would if you were going to hit it with the light initially. Does that make sense? Does that answer your question?
Yeah, it actually does. So thanks.
Okay. So one place that I found this.
If I can, we've got Go Lightly. It's in the Dropbox. She has a lot of comments. Sharon, do you want to add a few things here?
Well, can you hear me?
Yep.
We can.
I've been working with a SDF program, and usually we have an interval between when we do the SDF and the GIC. And we also use a fluoride varnish on top of the SDF to keep it in place.
Absolutely. And I'm going to get to that, Sharon, but thank you for that. So as you said, most of the glass ionomers, can someone mute for us, please? Thank you. Most of the glass ionomers, if it's a traditional glass ionomer, it is self-cure. So you could actually apply silver diamine and flow your glass ionomer in right over top of that, and the patient could walk out day of. Sorry for the feedback, guys. That's not on my
That's
end.
right. And glass ionomer is considered a sealant.
So Sharon, I can appreciate that. I'm not going to get into any of coding or any of the whether it be product specific tonight, but absolutely, I've heard that from other providers as well. However, the use of glass ionomer, like I said before, is still the preferred, especially in deciduous teeth, just because we know these patients are already high caries risk. And we have the ability now to use a material that is going to absorb fluoride, both from varnishes and from possibly like a 5,000 parts per million product. It's going to absorb, and then that material is going to release that fluoride back into that lesion. So it's kind of a win-win for the patient. But in terms of, Patty, you can go ahead. So I'm going to go over some uses, and then I'm going to go over application. And Sharon, I'm going to get to your point about the use of a fluoride varnish. So as we discussed, there's several uses for silver diamine. Dentinal hypersensitivity. So it's great to use for those cases where previously you were using Seal and Protect, or you were using Hurry Seal. You were using something to help those patients that are super cold sensitive or brushing sensitive. As long as it is a healthy tooth structure, it does not oxidize and turn dark. Now, having said that, I would still tell the patient, I have a great silver fluoride that I'm going to apply to this area. However, if there is something going on with that tooth structure that the doctor and myself haven't been able to pick up either on a radiograph or with your visual exam, there is a chance that there could be some darkening of a few areas. Now, I'll tell you, in using it as a desensitizer on a posterior tooth, most of those patients are going to say, I don't give a crap, and I don't care if there's a dark mark there. I just want my sensitivity to go away. And that's great. I always tell them, though, you're going to have the option, if that darkness, if something does show up, if that darkness does show up, the doctor then can go in and remove that and put something in that's more tooth colored. So it's not the end of the world if something turns dark. For us, it's a good thing. For us, the darkness means that the decay or the demineralized or the hypocalcified area has been affected by the SDF. So I completely turn that around when I'm talking to patients, that the dark is a good thing, and we can get past that if we can get them over that hump. So the second use, as you can see, is caries arrest. The time when you would not use it as a caries arrest is in an already symptomatic tooth. When you're already guessing there is pulpal involvement, SDF is not the medication to use for caries arrest. That is actually one of the contraindications, is no direct pulpal exposure. The other two would be a silver allergy, because it is silver nitrate. And the third would be it's not to be used on an open wound. Now, have I used it on a class 5 lesion in a highly infected gingivitis area on an elder patient? Absolutely. And have I had any detrimental effects from that? No. So the instructions still say, though, that you're not supposed to use it on an open wound. I even have hygienists who are treating their own aphthous ulcers with silver diamine and letting it burn for about 20 seconds. And then the antimicrobial effects is letting that lesion heal up fast. So you did not hear from me that I said to use it like that, but I do have hygienists in the field every day who tell me that they are using it on their own aphthous ulcers. So back to uses around existing restorative margins. So for us in our practice, this was a big one for those amalgams that you know are leaking, but that patient just says, nope, I don't want to do anything until you are sure, or until the filling falls out, or until it breaks, or until it hurts. So you can apply silver diamine fluoride right around all of those margins, let it soak in and do its job around all those margins that could be leaking. As a liner under new restorations. So many of my pediatric dentists tell me every day that they're using it as their caries liner. They're using it under, in general practice, underneath, before they are applying a temporary. After they've done a crown prep, they're applying silver diamine, which is acting as a desensitizer, so that when that patient comes back in 3 or 4 weeks to have those temps popped off, no longer is that tooth sensitive where they have to be anesthetized in order to do something, in order to put their permanent crown on. So it's a great desensitizer. Again, back to the desensitizing factor, indirect pulp capping. I have pediatric dentists every day telling me that they're using it as their indirect pulp cap. If they're restoring an area and they're excavating and it's going further than what they thought it was going to go, they stop. They apply silver diamine as the way to arrest the rest of that decay. And then they either restore or they bring the patient back for reevaluation. But in terms of an indirect pulp cap, they're having great success for those micro exposures, but not for full-on exposures, guys. That's not where it's made to use for. But really good study results coming back as use as a indirect pulp cap. So SMART technique. You're all familiar with what we used to term the ART technique, atraumatic restorative therapy. So now it's silver modified atraumatic, which means we have the ability to arrest caries and apply a restorative material right over that area without ever having to pick up a handpiece and without ever having to pick up a syringe to anesthetize. So we're not just talking about for kids. How about for that anxious patient that wants nothing to do with the doctor, but loves coming to see you as a hygienist, but the doctor makes them freak out and they don't want a needle and they don't want the handpiece? Well, now we have an option where we can treat those patients without having to do those things. So just another little niche where you might be able to use it in your general practice. As a sealant, we kind of already talked about that. The studies are kind of still out on that, so I can't say yes or no, but I can say that we're pretty positive that we're going to have some really good results in comparison to conventional sealants. And then the prevention side of it. Every day we're getting more and more studies that are coming back talking about that prevention side of SDF. So applying it to exposed root surfaces of our elder patients that we know are going to be at a high caries risk because of their dry mouth, because of their medications, because of their chemotherapy. We can apply it to these healthy tooth structures to help prevent decay. And this part of SDF is only going to get better. We're really trying, we've been going and trying to give testimony to try to get a preventive code for SDF, the preventive side. They haven't accepted it yet, but we're very positive that that's going to be coming as well in the future. So we're going to have something that we can use to use SDF as a preventive measure. Anyone have any questions? Patty, I know you want to say something. You want to say something? I know it.
So well.
I don't know. I just know.
I know there's things that you can and can't say, but and so this is a Patty DeGangi way of saying it. But for what you were talking about when you were first talking about the dental hypersensitivity, it actually has an aspect of being diagnostic.
Absolutely. Absolutely.
That's a really important word that was not on your slide. But again, with their traditional ways of looking at something radiographically or looking at something with our explorers, that's, it's pretty far gone already. If we're talking about using something like this that gives us information we didn't have before, there's an aspect of it that's diagnostic.
Oh, that's amazing, Patty. Thank you. Yeah, absolutely. And I would use that every day, like, let's say a partially erupted 6 or 12-year molar on a high caries risk child that you know darn well by the time that completely clears that tissue, it's going to be carious. So I am not treating, I tell the parent, I am not treating something active because I can't tell if there's decay there or not. But you best believe that if I could get something shoved underneath that piece of tissue to get it dried off, I could apply SDF with the microbrush, and I would tell the parent, and I would show them, we have a nice laminate that shows SDF use. This is probably what this tooth is going to look like when this patient comes back in. There was probably something there early. It may be dark. Dark is a good thing, but I'm still using it as a hygienist in the preventive way with hopes that there isn't going to be a huge gaping hole in that tooth. But we know now that if it turns dark, that we got that decay at its earliest possible time, and it turned hard like a rock. It is absolutely incredible when these teeth come back in, and now you see some darkness in that groove that was once covered by tissue. So it's pretty cool stuff. Thanks for bringing that up, Patty.
Connie, this is Tasha.
Yes.
I have a question.
Tasha, go ahead.
Yes. So if today there's not a preventive code and we're not using it for hypersensitivity and we're not using it for caries arrest, what do we code out if we're wanting to use it around crown margins for preventative measures?
So I'm not going to get into anything with coding, Tasha, because as you know, that's actually what our whole codology thing is about. I can just tell you that practice by practice, they're deciding on their own because we don't have a preventive code. Keep in mind that silver diamine is still a fluoride. So I do have some offices, you're not using it full mouth, they are using it on site-specific areas, but some offices are utilizing our nondescript 1208 fluoride code for those instances. May or may not be a chargeable thing, not a chargeable thing to third party. What their practice decides to do with it is completely up to them. And I know, Patty, you want to chime in.
You know I'm going to jump in on that one.
Oh, I know. Go, girl.
Let's not mix up again three things: code, fees, and coverage. They're not the same. If we start thinking coverage, when we start thinking about whether we're charging something or not, if we start thinking coverage when we're thinking about coding or not, that's where things get problematic. Codes are nothing more than the identification of what treatments that we've done, and there's a code for everything, and it's really important that we use a code. Now, when I say there's a code for everything, there might not be the code that we want to have. That's part, again, that we were talking about earlier about helping formulate the codes. But there's always a code because there's always a 999. And if we could be using silver diamine under a 2999, which is unspecified procedure, unspecified preventive procedure by report. It could be a 499 stereo. Just really depends. Coding depends on the diagnosis, not depends on the product. I can talk more about that later, but I'll let you keep going here.
Yeah. Thank you. Thank you, Patty. So I see a question, how long does it take to turn black? So that varies on the lesion, and it varies from day to day. So you could, and most of the time you're going to see it start to turn some shade of dark as you're applying it, but it will reach its maximum depth and its maximum darkness by 48 hours. So there are some times when I know it's a carious lesion and we have diagnosed and we have applied, and I'm like, by gum, it's not turning. And that parent or the patient the next day will call me and say, oh, I looked in my mouth and it's dark. So most of the time you will see it, but it does get darker within a few hours. Even if you get it on your soft tissue, on your hands, you might think, I got away with it and it didn't turn. Oh no, you're going to know in a couple hours because you're going to start seeing the staining on your hands. So I'm going to go over application here real quick, and then I'm going to talk to you guys about some of the staining properties, get back to that. So hopefully that answered your question. So it's a very general application for silver diamine. It is not brain surgery. Super, super easy. So basically you clean the site however you're able to clean it. Please try to mute if you're on a phone so we don't get background. Sorry, guys.
So please, whoever's got their phone open, please mute their phone so we can hear. Thank you.
You clean the site. So in our office, that might mean pumice and Profi cup. In a nursing home or in a missions trip, that's a toothbrush Profi. It does not have to be. It does not have to be 100%. You want to get off food debris and you want to get off as much plaque and debris as you can. So you clean to your degree that you're able to. You isolate the site. And again, this is completely up to you and your comfort level. When I first started applying silver diamine, that means they had cotton in every place possible. They had cotton angles and cotton rolls, and any place that I could get cotton, they had it. Now that means for me a dry angle in the cheek, a cotton roll if it's on the lower buccal and lingual, and maybe a little bit of Vaseline petroleum jelly on that side of their lip where you might be retracting back. We do know that Vaseline, some offices will put a smear layer over the lips and over the cheeks if they think that they're going to have some contamination of the outside. But really, that all comes down to what your personal comfort level is. It gets easier the more that you do it. So now you pick up, so you dry the site, and again, in an ideal situation, we dry it the best that we can with our air water. You dry the site, If you have to use cotton when you're in the field, use cotton. If you have to use gauze, I don't care what you use, but the drier the site, the better. So we apply it with a micro brush. Doesn't have to be a particular micro brush. You've placed your silver diamine in a disposable dapping dish. You don't want to use glass because it will corrode the glass, and you definitely don't want to use metal because it will interact with the metal. So you want to use something plastic. So you put your silver diamine into the dish, you pick it up with the micro brush, and you apply it to the lesion. We want to try to leave it in contact, if we can, for about 60 seconds. I have providers who are doing it up to 90 seconds. The problematic side of that is if we're doing it on a pre-cooperative 3 or 4-year-old, we know there is no way we're going to get a minute of soak time and keep things dry and keep their tongue out of the way and keep their hands down. So our pediatric world really takes the silver diamine, scrubs it into that tooth structure for about 10 to 15 seconds, if they can get that. And like Sharon said before, picking up fluoride varnish, applying right over top of it to seal in that silver diamine. It's going to prevent their tongue from going straight to it. It's also going to help mask some of the taste of silver diamine. It's not required, but I would say probably 95 or more %, if you're not restoring day of, are applying a fluoride application, varnish application at time of. And then you release the patient. There is no restrictions on eating, drinking, rinsing. They can, if they want to go to the sink and rinse right now, they're welcome to. So that's it. It's not difficult. It gets easier the more that you do it. You want to protect soft tissue. Patty, you can go on to the next slide. So it does not stain sound, enamel, or dentin. Does not stain when preventing sensitivity, as long as it's healthy structure. Does discolored when applied to demineralization. So this is not made for white spot lesions around ortho brackets, because now they're going to be dark spot lesions around ortho brackets. But we know that that color change is a good thing. It does discolor soft tissue. It looks like an amalgam tattoo inside of the mouth. If you do get it on soft tissue, which you're going to get it on soft tissue when you're doing class 5s, you're going to get it on soft tissue when you're treating interproximal. However, that goes away. Our skin sloughs. So an average, I'd say anywhere from 3 to 13 days. Most people I'm hearing around 4 or 5 days, the discoloration is gone. Super good if you do get it on your skin or on the patient outside of their face. Hydrogen peroxide is really effective at getting it off right away. I would use hydrogen peroxide. And then if you get it on hard surfaces, like your countertops at work, if you drop it on the floor, magic erasers work wonders for that. And I have an office who uses magic eraser and the hydrogen peroxide together. So it does come off soft tissue. So don't let that be the reason why you're not using it. Okay, Patty, you can go forward. So here's some pictures, guys. I know we're running out of time. I don't want to keep you real late, but these are some good befores and afters. So this is what one of those high-risk sites would look like after the application of silver diamine. You can see the darkness. Those were areas that were decayed in some way, shape, or form, and that's what it looks like. When you run over it with an Explorer, it feels hard rock like concrete, like you were running over concrete, and that's how you know that it is arrested. Okay, Patty, go forward. So these are some befores and afters. That is obviously the tooth before, and that's what the decayed area looked like after they treated that. And so that's going to be up to the parent or the patient and the provider what they want the aesthetics of that tooth to look like. If they don't care that they're going to flow some opaque glass ionomer into that, that's absolutely what they could do. They could flow material right over top of that, and you're going to see that here in just a second. Patty, you can go forward. So using SDF as a liner for secondary decay, you can see how close we are to pulpal exposure. They took out an old composite and there was decay underneath it. Okay, Patty, next. That's what it looks like arrested after the application of silver diamine, after they prepped the tooth out. They didn't want to keep excavating because they knew they were going to have pulpal exposure. So in this case, they used it as their liner. Okay, go forward. And that's what it looks like finished with composite. Now you can see that there's darkness underneath that. That's why it's super important that you are always making sure that you are coding out correctly for the procedure, that you utilize the D1354 code, which is utilized for caries arrest, so that everyone knows that you use that medication, and that's what the darkness is. It's not decay. Anyone have any questions about the darkness or what it looks like underneath restorative material? Okay,
no, but I'm
Patty.
going to throw out something else. If I can, Connie, I'm going to throw out something else for people to think about. Our tradition in dentistry has been when someone changes practices, we only send x-rays. I think that something has to be highly questioned in the day and age that we're in now. This would be a good example why. If someone went to another practice and they didn't have any record that SDF was used, what could that lead to? In the same way
Absolutely.
that when someone goes to a different practice, they lose their periodontal history, they might not qualify for 4910 treatment because we don't have the record of it. Record keeping is extremely important, and even more so now that we have this type of product. Patty B has a question.
I don't have the question. Noelle had the question. But the question is, does SDF show up on radiographs?
I didn't get that. Sorry, Patty.
Does it show up on radiographs?
So yes, a lesion that has been arrested with silver diamine looks exactly the same as the lesion did before you arrested it. So that's why, as Patty was saying, documentation is super important, because I had a patient who came as a new patient, and I saw several lesions on the radiographs, what I thought were lesions, before I even went into the room. My assistant had taken some bite wings, and the minute I walked in, the patient told me, hey, my previous dentist wanted me to make sure that I told you they used silver fluoride on those lesions. So thank you, patient. But yes, so that's one of the things. And because now we have digital radiographs, we can actually blow the lesion up. Some of our providers are telling us after about 2 years' time that now they're starting to see some difference in what those lesions look like, because the fluoride is actually acting as a remineralizer. So we're actually getting some density changes, but it does take some time. So it does look exactly the same on a radiograph before and after treatment. And no, Brittany, the darkness does not go away under the composite.
Speak to what somebody put in the chat box about they thought this was an hour long. One of the things about Mastermind is because of the discussion, we never quite know how long they're going to be. If you do need to leave, we understand. You did say your hour, and you are welcome to leave. And again, it will be recorded and online if you want to listen to the rest of it. So go ahead.
And we're almost finished, guys.
Leave people alone. Do what you did to Pete and keep things clear to you. Indy. Okay, off.
Okay, so this is, yeah, I'm here. Are you there?
So I just can't go forward. We heard whatever that disruptive noise is.
Yeah, I don't know. It wasn't me. But so this is the use of a Hall crown, which is a pediatric dentist, that, as you can see here. Go ahead, Patty, you can go forward. That's what it looked like arrested. Go ahead. They placed the glass ionomer right over top of it. So as you can see, glass ionomer isn't the best in terms of aesthetics, but it's an awesome material for these type of lesions. And then go ahead, Patty. They placed a stainless steel crown right over top of that glass ionomer. So the patient was able to have a lesion, the carious lesion arrested, the material placed in the lesion, and the stainless steel crown placed without any local anesthesia and without doing any prep of the tooth. So pretty crazy stuff.
Dude, I don't think she's following you. I think she's just doing her own thing.
Okay, Patty, you can go forward. So here's what SDF could look like. So this is maybe a mouth that I would see when I go in and treat these kids in the schools on mission trips. If I'm hitting all of the occlusals on their posterior teeth and they have rampant decay, this is something very similar to what we would see. However, now this patient has an option. If that tooth is close to exfoliation, they might just want to leave it there for a year or two. If that tooth, if the parent doesn't like the darkness, something can be flowed over it. The provider has the option of removing all of the staining, removing some of the staining, or removing none of the staining. So that's the option of what the aesthetics, the final aesthetic outlook is between the patient and the provider.
Question. Somewhere along the line of the last week, somebody asked me something about, is there effect to the permanent tooth when you treat a deciduous tooth with SDF?
So there's a lot of feedback, Patty. Someone has their phone open, sorry.
I'm not sure how we can control it.
Yeah, I'm sorry.
What I was asking is somebody asked
She doesn't
me
know how to go out the doggy door yet.
about SDF and effect on the permanent tooth when it's applied to a deciduous tooth. Is there an effect? Is there something we might see when they've exfoliated the deciduous tooth after being treated with SDF?
So there is that possibility that the SDF could go to an adjacent tooth or an adjacent surface. That's kind of the risk that you take. However, our product is tinted blue, and if you're pretty careful about where you're applying it and you're careful about your isolation with the cotton, if you're concerned about it, if there's still a lot of that blue tint left on that lesion, before I apply my fluoride varnish, sometimes I just pick up a cotton roll or a cotton pellet and I absorb any of that extra liquid that might be there that I might fear might go someplace else. So there is that possibility. I have seen it creep down and stain plaque, marginal plaque that's been a patient that's had poor oral hygiene, but that's something that I brushed right off with the toothbrush right afterwards. So I haven't had a whole lot of problem with it unless it is just a mouth that's completely full of white spot lesions. That SDF is going to cling to those spots. So it is a possibility. I think that, yeah, that's the last. So who has questions?
So thank you again, Connie. You're amazing. You've done a great job. Anybody have any residual questions, comments, anything? We really appreciate. I apologize. We have no idea why the audio was what it was tonight. We never had that problem before that much. Again, I apologize for it. We did everything that we can on our end to try and take care of it. Connie is available, not just Connie, but Elevate Oral Care. I want you to write this one down because they have more continuing education programs. They'll come into your practice. Actually, Connie, talk about them if you don't have. Talk about how that works with Elevate.
Right. So we're still a super small company. We're less than 30 employees company-wide. I'm only number 14 rep for the entire country. We only have about 11 states covered because we're still so small. However, that doesn't mean that you don't have the opportunity to have a live go-to webinar in your office where we would do just like we were if we were standing in front of you. You will get mailed an incredible box of samples, and the representative on the other end, you'll schedule that time that's good for your team, and they will go through product by product. They'll talk about SDF, they'll talk about all of our other amazing preventive products. And for us guys, the preventive world, just log on to elevateoralcare.com, take a look at our research, take a look at our line of products that just cover us in terms of everything from A to Z for these high-risk patients. And if your office would be interested, if they do lunch and learns, click on one of those buttons for request a staff meeting. Someone's going to call you or email you and get that set up so that your whole entire team can get the important education on this medication. It's just going to change our world for dentistry, all for the better.
And in my opinion, I think one of the really important points that you made earlier is it could be considered substandard not to offer it because we have this really powerful arrow in our armamentarium now. And do we have a right to decide for our patients that we're not going to even offer this service? I think that's a really key question for us to consider. Is there a code? Yes, kind of referred to it before. The code that we have now is a 1354. As you can see there, interim caries arresting medicament. What is really important to understand is codes are not product specific. There are 2 products in the US now that have clearance. I think it's really important for you to understand what the mechanism of action and how these various products work. But codes are not product specific, but codes are really important to use. So I really want to thank Connie. I want to thank all of you for your patience. I welcome you to again consider joining us. You can, our next mastermind, as I said earlier, is on the 18th of November, and this is with Daleen about water. Again, if you want to join us, this is a one-time only SDF-2019. It will expire in a week if you want to join us as a member. I appreciate everyone here. I appreciate your time and your expertise. Again, I'm easy to find on texting, email, Facebook, Instant Messenger, any way that I can help you. What I believe is that dental codology and all of you here are charting the future. We're making our future, not just waiting for it to happen. Again, I thank all of you for your time and your attention and wish you all a good night.